So high quality endoscopy is impossible if the patient is not comfortable. Propofol is ideal but not universally available. So what are the other options? Transnasal endoscopy is the option of a less invasive, a less uncomfortable procedure, and we will have a presentation about that later. Remimazolam is an alternative to other conscious sedation agents, and I can't wait to hear David Tate's presentation on this agent, which I've not used myself. I will be particularly interested to know whether the patient is not just having better amnesia for the episode, but actually they're quieter and more relaxed during the procedure and moving less, because that's what's important to me as an endoscopist.
Me and Monica are here with a patient who's got a genetic predisposition to gastric cancer. It's mother with linea dysplastica, unfortunately at the age of 55, genetic testing, CDH1 variant. This is his first screening gastroscopy. We are using Remimazolam, and the patient is nicely sedated and almost completely asleep. I don't know what you think, Monica, that we're getting pretty decent views here with this situation. Probably much better view. Look how distended the stomach is. I don't think we'd be achieving that with standard midazolam or no sedation. What do you think?
The patient sleeps well, so we have a good sedation for these patients, and everything it stays like this without Buscopan. The stomach is quiet, so that's perfect.
Everything's perfect for us.
Everything is perfect for us to take the picture. And
would you agree that given the blood there is making the eye scan incredibly difficult, that you should have looked at the esophagus first?
No, Roland, I wouldn't. I would want to push back on that, of course. But yes, it would have helped, of course, if I looked at the esophagus first.
Well, it's probably worth saying that the reason we switched to digital imaging and look at the blood vessels is because you're going to pick up squamous pathology more easily, which is the one that's usually missed. And this highlights that.
I think we can also say this is a young patient and the risk is in the stomach. But we are also getting pretty good views with white light, I would say. We're not messing it up too much from the blood. But yeah, you're right. If I had looked to start with, then we would not be having this problem.
Yeah.
but the bleeding stops immediately, so
exactly.
You can do it. You can do it after.
It really got the stomach distended, and we didn't hear a thing until the hiccups at the end of the procedure, but they worked pretty well because you wouldn't be able to stand that, I think, if you were fully awake. Would you agree? Or
so it's probably a deeper sedation with the Remimazolam without the significant respiratory depression, or it would appear so. So it'd be interesting what David's got to say with it. But from the sedation perspective, it worked very well. And I think the hiccups, along with ptosis, are a class effect for the benzos. So it's just a byproduct of the medication.
Together with the distension, perhaps a bit of.
Paul and Vikash to comment?
I don't know, Paul, if you want to make a comment. Oh, Paul, we can't hear you.
You're muted.
Can you hear me?
You can hear you now, yeah.
Yeah.
Yeah. So, like Ren, I've not used Remimazolam before, but it certainly seemed to give a good sedation there. Certainly, when I speak to the anaesthetist about Remimazolam, they are very positive about the use of it. So, again, I've been interested to see what David has to say about the pharmacodynamics of it.
Second study is a meta-analysis comparing 3 randomized trials, 528 patients, Remimazolam versus midazolam. Procedural success higher with Remimazolam, odds ratio of 9.78. Need for rescue medication, lower for Remimazolam, odds ratio of 0.09. And fewer adverse events, especially hypotension. So here is the figure for hypotension, and you can see it significantly favors Remimazolam. And here is the one for adverse events in general, and this also favors Remimazolam. So in summary, safer, more effective, and faster onset, and definitely faster offset than midazolam. Finally, versus propofol. So this is where most of the data is, because it's been relatively kept in the anesthetic quarter, this drug, up until recently.
One is, in the randomized controlled trials, did they use an opiate with the midazolam when they were comparing?
Not sure I know the answer to that off the top of my head.
Second question, or really a comment, is that my experience of midazolam, and you sort of hit the nail on the head, is that it's unpredictable. And one of the problems with OGD, and you give more midazolam, is you can get an increasingly uncooperative patient, particularly younger men, and then they just lose all inhibitions, and it's absolutely dreadful. So you don't get any benefit from increasing the midazolam, but you actually get a big downside sometimes. And in those it does sedate well, then you're a bit worried about their ventilation. So I think something that doesn't have those problems, and it sounds like Remimazolam doesn't have those problems, would be very attractive.
But I think these two talks are really juxtaposed against each other. Roland wants everybody deeply sedated so that he can do an excellent upper GI exam.
No, I don't.
Now we're having unsedated patients who are getting air or CO2, so they're getting their stomach just as distended as everybody else is. And we're worried about them possibly not tolerating it as well. I understand the difference between the OGD and the transnasal, but and the data was interesting, and there's local success. I think it's very much cultural as well, and how much education you put ahead to it. But even in an expert's hands, 20% of his patients don't want to undergo it again. So that's a bit different than a sedated OGD.
Transnasal endoscopy has been around for quite a long time, and certainly you'll see this used routinely in ENT clinics in fibre optic endoscopy. And the preparation is really quite similar. So this is often done unsedated. And what we're aiming for is the space between the septum and the inferior turbinate. Now, the difference between ENT and our image is it's flipped. So we're usually aiming for the top, in this case, top left, and they would be aiming for the bottom. But essentially, the theory is the same. You're aiming for the space in the corners. It can be quite tricky. You really want to avoid touching the septum at all. But with the current newer model scopes that we have, they're very slim, 5.8 mil wide, but they have a wider working channel, 2.4 mil for the latest Fuji scopes, which really allows you to get the suction that you need when you're in the stomach, although you still can't put down therapeutics such as APC, for example. So this is purely diagnostic.
He does regular T&E, and he never uses sedation, and he finds it very effective in the ambulatory setting. I think that's what he was saying.
And wondering if we then give too much sedation, and if
I think the whole point of this, wasn't it, Roland? The whole point of this session in here, because I think in Europe we have very little TNA adoption, certainly in Belgium, it's not widely accepted, is to open a conversation about exactly that point, and whether we can, certainly replace some of our sedated endoscopy practice or unsedated gastroscopy with a better tolerated, similarly diagnostic procedure. I don't know.
Well, I mean, I would ask the question of why on earth it hasn't been adopted in Europe. You know, I can imagine if I was running a business of an endoscopy, it would be actually a marketing benefit. You know, you're saying, well, I can do the procedure after work. You don't have to have sedation. I'm not interfering with your lifestyle. You're going to have just as good an examination. You know, what's not to like?
So I think the problem is the technology's advanced, Roland. So initially, I think the quality of the images was so poor, they didn't think it was going to replace conventional endoscopy, and like everything, things get better and smaller and neater. And the other issue was really the ability to do biopsies, which has been addressed by that video. But so I think the technology has advanced to the point where we need to be thinking about how it becomes part of your complement of investigations available for the patient.